Hello, good afternoon. It's an absolute honor for me today to introduce the next speaker, Dr. Madhusmita Mishra, or Madhu as she's fondly called among us boneheads in the PES. Dr. Mishra is the Fritz Bradley Talbot and Nathan Bill Talbot Professor of Pediatrics at Harvard Medical School, Chief of the Division of Pediatric Endocrinology at Mass General for Children, the Medical Research Officer for Massachusetts General Hospital through the Harvard-wide CTSA, and the Associate Director for the Translational and Clinical Research Center at MGH. She is also a past president of the Pediatric Endocrine Society. She has primarily worked on neuroendocrine and bone alterations in conditions that span the weight spectrum from anorexia nervosa to exercise-induced amenorrhea, to obesity in adolescents and young adults, and on bone outcomes in children with autism spectrum and diabetes. Dr. Mishra, we're really looking forward to hearing your talk. Thank you.
Oh, thank you so much, Samia, for that introduction, and thank you all for the invitation to speak here today. I did not realize this was a hybrid meeting. Otherwise, I would have been tempted to not travel, but I'm really glad I did because it's just so nice to see people. This is, in fact, my first in-person meeting. So I'll be talking about reproductive and bone health in athletes, and just be sure I got this right. Yeah. And these are my disclosures, none of which are really current at this time, but I thought I would put them up there. And I will be discussing the off-label use of IGF-1, metroleptin, teriparatide, bisphosphonates, and also denosumab. Now, ever since Title IX went into effect in 1972, we know that sports participation amongst girls has gone up many fold, more than tenfold. And a few years ago, when we looked at the numbers of women who participate in running sports in the United States every year, it was about 28 million. So this is a large group of people that could potentially be impacted by what I'll be talking about, which is the female athlete triad. And while we know that sports participation has many benefits, of course, it can cause this condition that is referred to as the triad. So the female athlete triad refers to the triad of low energy availability, leading to menstrual dysfunction and low bone density. But the triad is in fact a spectrum, and the spectrum for energy availability ranges from optimal to reduced with or without disordered eating behaviors to frankly low, again, with or without an eating disorder. And menstrual function can range from ovulatory eumenorrhea to subclinical menstrual disorders, including luteal phase defects and anovulatory cycles, to frank oligoamenorrhea. And bone health can range from optimal to low bone density to osteoporosis. Now, the IOC, the International Olympic Committee, came up with another way to represent low energy availability, and this is how the term REDS came into being. So REDS is relative energy deficiency in sports, and this wheel shows the many consequences of relative energy deficiency in sports. Now, many people talk about REDS as having replaced the female athlete triad, and it really has not replaced it, because REDS can cause menstrual dysfunction, can cause low bone density, and the triad is still, right here. Oh, you can't see my my arrow here. Okay, let's see if this works. Let's see. Whoops, I messed up something there. Whoops. Okay, what did I do? You're back. Thank you. All right, yeah. Why do I do this? Okay, thank you. Terrific, thanks so much. So the triad is right here. So it's really not that REDS has replaced the triad. Relative energy deficiency in sports is another term for low energy availability. So what I'm going to do today is review the components of the triad, and I'll start with low energy availability. So this term refers to the difference between energy intake and exercise energy expenditure standardized for fat-free mass. And energy availability is believed to be optimal when it's more than 45 kilocalories per kilo fat-free mass per day. And it's believed to be low when it's less than 30 kilocalories per kilo fat-free mass per day. And these numbers come from a series of very elegant experiments by Anne Laux and others who admitted healthy, normally menstruating, non-exercising women to a CRC setting, and they exposed them to different degrees of energy availability. And they showed that when energy availability dropped to less than 30 kilocalories per kilo fat-free mass per day, there was a change in the pattern of LH pulsatility. Now, one caveat to these numbers is that these numbers are based upon acute phases of energy restriction, and this may not be applicable to athletes who may be in a chronic state of energy deficit. Now, when do we see a state of low energy availability? Well, this occurs when there is a high volume of activity in the face of insufficient dietary intake, leading to that state of relative energy deficit. And who are the athletes who are most at risk for the triad? Well, these are, or low energy availability. And these are those athletes who engage in endurance sports, such as running, cycling, swimming, and rowing. Those that engage in leanness sports, such as gymnastics, diving, and ice skating, and sports in general that are associated with a lower BMI and a higher degree of dietary restraint. And that would apply to all these sports activities that I've just mentioned. So now moving on to menstrual dysfunction. So this, of course, is the reproductive axis, and with normal functioning of the reproductive axis, there should be normal secretion of estradiol, testosterone, but also testosterone and dehydroepiandrosterone from the ovaries, and these are all the gonadal steroids. Now, in states of low energy availability, there are many endocrine changes that occur that I'll be talking about in greater detail in subsequent slides that lead to an impairment of gonadotropin-releasing hormone pulsatile secretion. And these changes include higher concentrations of cortisol, ghrelin, peptide YY, and adiponectin, and lower levels of leptin, insulin, and IGF-1. And these changes are mostly adaptive to the state of energy deficit, as I'll talk about a little later. But these endocrine changes will lead to altered GnRH pulsatile secretion and altered gonadotropin pulsatile secretion with decreased secretion of the gonadal steroids. And this too is adaptive because reproduction, we know, expends a significant amount of energy. And in conditions of energy deficit, we want to conserve energy for the most vital body functions, and reproduction is not one such function. Now, it's important to recognize that menstrual dysfunction occurs even in normally cycling eumenoric exercises. And this was very nicely represented in this study by Mary Jane D'Souza and her group in Penn State, where they compared eumenoric runners with sedentary controls and showed a very high prevalence of luteal phase defects and anovulatory cycles in the eumenoric runners as compared to the controls. And at the extreme end of the spectrum of menstrual dysfunction is oligoamenorrhea. And the prevalence of this really depends upon the nature of the physical activity, the intensity of activity, and the nutritional status of the athlete. And it's important to recognize that this can be seen in up to 62% of adult endurance athletes and in up to 24% of adolescent athletes. So this is very prevalent. Now, the amenorrhea that we see in athletes is functional hypothalamic amenorrhea or functional hypogonadotropic hypogonadism. And this refers to amenorrhea that occurs in the absence of any organic pathology. And we see this in excessive exercises. We see this in low weight conditions such as anorexia nervosa. And we see this in conditions of excessive emotional stress. And athletes can actually have a combination of all three. Now, in 2017, a group of us got together to write the Endocrine Society guidelines for the diagnosis and management of functional hypothalamic amenorrhea, and I will be referring to the guidelines over the course of the talk today. So now the diagnosis of functional hypothalamic amenorrhea is a diagnosis of exclusion, and I'll go through a case just to talk about how we diagnose these patients, and also I'll continue this case. Talking about this case as we talk about the management. So this is a 17-year-old young woman who came to me with a history of multiple stress reactions and fractures involving the distal femur and the tarsal bones. She had attained menarche at a normal age of 13 years, but since menarche, she's had only 5 spontaneous menses. So she has oligoamenorrhea. And what really raises concerns right away with that history is that she's a cross-country runner. And when you look at the growth chart, she's been at a low body weight for height for many years. So on exam, her weight is at the 54th percentile, as shown in that in the growth chart, which seems very, very normal. But then she's very tall. Her height is above the 95th percentile. And this gives her a body mass index of 18.5, which is at the 12th percentile, and only 86% of median BMI, or 86% of the 50th percentile of BMI for age. So 100% median BMI for her is 20.9, which corresponds to a weight of about 150 pounds. And 90% median BMI, which is the target that we often talk about, corresponds to a weight of about 135 pounds. So she's not too far from that 90% median BMI weight, but she has this history of oligoamenorrhea. She's also bradycardic, and otherwise the exam is quite unremarkable, other than some mild hirsutism, and she's fully pubertal. So what would you like to do in this patient? So the workup for amenorrhea in athletes really requires us to first rule out other causes of amenorrhea. So we want to rule out pregnancy, thyroid dysfunction, other causes of hypogonadotropic hypogonadism, hypergonadotropic hypogonadism, conditions of hyperandrogenism, such as PCOS, adrenal tumors, and non-classic CAH, differences in sex development, and medications that can cause amenorrhea. And the history and the physical exam should be geared towards ruling out these other conditions, but the history should definitely include an evaluation of the volume and nature of activity, menstrual function, and eating patterns and such, and also a history of fractures and any previous assessment of bone density. And the physical exam should definitely include an evaluation of the external genitalia and also the hymen to be sure that this is not a patient with an imperforate hymen who has cryptomenorrhea. So these are the labs that we typically obtain, and our patient was not pregnant. She had normal thyroid function, normal prolactin. The gonadotropins were not elevated, and there was the pattern of FSH predominance that we often see in patients with functional hypothalamic amenorrhea. The estradiol levels were low. Testosterone was low normal. DHEAS was normal, and we did not do a 17-hydroxyprogesterone. So what should the next step be? Should we get a morning 17-hydroxyprogesterone in her? And you could, except that it's not going to be very high yield in this patient who has very minimal hirsutism and nothing really else in terms of hyperandrogenism. Now, what about a progestin challenge test? So with this test, so if the uterine endometrium has been exposed to a sufficient amount of estrogen over time, after 3 to 4 days of the progestin challenge, there should be a withdrawal bleed. So this is a great test to assess the degree of estrogenization of the uterine endometrium in patients with secondary amenorrhea after you rule out other causes of amenorrhea. It is not recommended as the next step in primary amenorrhea because in those patients, it's best to first assess the intactness of the internal genitalia before doing the progestin challenge test. Now, what about a full bimanual or pelvic examination? Now, this is reasonable in an adult woman who is sexually active and a teenager who may or may not be sexually active. We tend not to do this so much. And for imaging studies, for the internal genitalia, if that needs to be assessed, the pelvic ultrasound is preferred to the MRI as the first step just because of the expense. And the brain MRI may be necessary in particular patients, particularly when there is a history of symptoms that might be suggestive of a space-occupying lesion. So our patient did have a negative progestin challenge consistent with being hypoestrogenic, and she did receive a diagnosis of functional hypothalamic amenorrhea consequent to excessive physical activity, just given the history and the evaluation that I've just talked about. So what should the next steps be for her? What should we do next? And this brings me to the third component of the triad, and that is low bone density. So obtaining a DEXA scan to assess bone density would be a reasonable next step in such patients because this is a major consequence of low energy availability and menstrual dysfunction. So over the next few slides, I'll be talking about the impact of athletic amenorrhea on bone and the mechanisms that contribute to those bone changes. Now, in athletes, because of the mechanical loading that we see in these young women, now this should have adaptive effects on bone that leads to a stimulation of the osteocytes, which are the mechanosensors of bone, And this should lead to a decrease in sclerostin, which otherwise inhibits Wnt signaling and osteoblastic activity. So if you inhibit an inhibitor of osteoblastic activity, there should be an increase in bone formation and an increase in bone density. And this is important to withstand the impact of bone loading activities and to prevent fracture. Now, these adaptive effects of mechanical loading on bone appear to be lost in conditions of low energy availability and hypergonadism. So this is a study that we did several years ago. Carla Cristo was the first author of this paper. So this was a study in normal weight athletes, mostly runners and non-athletes between 12 and 18 years old, with the oligoamenorrheic athletes shown in red, the eumenorrheic athletes in lighter blue, and the non-athletes in darker blue. And at the lumbar spine, you can see that so the lumbar spine is to the left, and you can see that the oligoamenorrheic athletes have lower bone density than both the other groups. And at the femoral neck and the total hip, we see that the eumenorrheic athletes have higher bone density than the non-athletes, and this is consistent with the adaptive effect of mechanical loading on bone. But this adaptive effect is not seen in the oligoamenorrheic athletes who have lower bone density Z-scores than the eumenorrheic athletes. Now, we're particularly concerned about these changes in bone or the impact on bone in adolescents who engage in athletic activity, because we know that the adolescent years are critical for bone accrual towards the attainment of peak bone mass, which is a key determinant of bone health and fracture risk in later life. And the concern is that if there is any insult that occurs during the adolescent years that leads to reduced bone accrual, that could lead to low bone density and lower peak bone mass, and therefore impaired bone health and increased fracture risk in later life. And if this dashed line is the fracture threshold, we can see how a woman who attains normal peak bone mass in blue would get to the fracture threshold much later than a woman who attains suboptimal peak bone mass, shown in red. So we have looked at bone accrual in athletes and non-athletes and have shown that the eumenorrheic athletes in the light blue have an increase in bone density Z-scores over time over a year that is not seen in the oligoamenorrheic athletes in red. Now, so far, I've shown you data for DEXA measures of areal bone density. So bone density ideally should be measured as bone mineral content over bone volume, because density is mass per unit volume. But DEXA reports bone density as bone mineral content over cross-sectional area of bone. So this is areal bone density. And as I'm sure you all know, this will underestimate bone density in short individuals and overestimate bone density in tall individuals. And so because there are certain kinds of athletic activities that are favored by shorter people and others that are favored by taller people, it is important to keep this in mind and to adjust for height and at the extremes of height, not just for athletes, but for everybody. Now, also, DEXA does not provide any information regarding the cortical and the trabecular compartments of bone or about bone geometry or bone structure. And these are all contributors to bone strength. And these, all of this can be assessed by an instrument referred to as high-resolution peripheral quantitative computer tomography, which is a very useful research tool. It's not yet available for clinical practice. And there is a strategy that we often employ to assess bone strength, and this is finite element analysis. And in this analysis, virtual compressive forces are applied to virtual reconstruction of bone from HRPQ-CT images to assess breaking strain. So I won't have the time to talk about the HRPQ-CT data, but I just want to show you some data for finite element analysis measures of bone strength in athletes and non-athletes. And this paper was first authored by Kate Ackerman in our group. And we showed that at the distal tibia, shown to the left in that figure, and this is a site of weight-bearing bone. The eumenorrheic athletes in lighter blue have higher bone strength than the non-athletes, again, consistent with the adaptive effects of mechanical loading. But this adaptive effect is not seen in the oligoamenorrheic athletes. And at the distal radius to the right, we see that the oligoamenorrheic athletes have lower bone strength than the non-athletes. And this is a site of non-weight-bearing bone. And there's a difference in terms of how mechanical loading impacts these different sites and also the hormonal contributors to these differences that I, again, won't have the time to talk about today. But all of this translates to a higher prevalence of all fractures to the left, and particularly stress fractures to the right in the amenorrheic athletes compared to the eumenorrheic athletes and the non-athletes. And this is typically why patients would present to us in clinic. And the figure to the top shows the percentage of subjects with stress fractures at different ages. And we can see how the eumenorrheic athletes in the lighter blue have stress fractures happening between 13 and 16 years of age, which is typically when fractures are happening in people in general, in kids in general. But then in the oligoamenorrheic athletes in red, we see that that keeps going up over time. Now, there are many factors that contribute to impaired bone health in athletes and conditions of low energy availability in general. And these include body composition changes, hypergonadism, a state of growth hormone resistance, relative hypercortisolemia, alterations in appetite regulating hormones, and some other hormones that I won't have the time to talk about today. Now, calcium and vitamin D intake is also important, but just supplementing calcium and vitamin D is not sufficient to improve bone health in these young women. So in the next few slides, I'll be talking about data related to these mechanisms for amenorrheic athletes where those exist, and otherwise I'll use data from adolescents with anorexia nervosa, which is another condition of very low energy availability. So a major contributor to low bone density is altered body composition. So these amenorrheic athletes compared to eumenorrheic athletes have lower body mass index and lower lean body mass. And lean body mass is a very important predictor of bone density at almost every site. And this has been attributed to the pull of muscle on bone being osteogenic. And with weight regain, the increase in lean body mass that occurs is very predictive of increases in bone density. Also, we have shown that, that athletes with amenorrhea in red have higher marrow adipose tissue than non-athletes. And this suggests that there is increased differentiation of the common progenitor mesenchymal stem cell in marrow along the adipocyte lineage versus the osteoblast lineage, leading to more adipogenesis in favor rather than osteoblastogenesis. And higher marrow adipose tissue per se leads to reduced biomechanical strength of bone, and our studies and others have shown inverse associations of marrow adipose tissue with bone density and strength estimates. And because both lean body mass and marrow adipose tissue will change in the right direction when there is an improvement in energy availability, it is very important to emphasize optimizing this over time. Now, moving on to hypergonadism. So estrogen, we know, has important effects on bone. It inhibits osteoclast-induced bone resorption through its effects on osteoprotegerin and rank ligand secretion by osteoblasts. But it also increases bone formation by inhibiting the secretion of sclerostin and preadipocyte factor 1. And these are hormones that otherwise inhibit osteoblastic activity. So again, inhibiting an inhibitor would lead to an increase in bone formation. And our studies and others have shown very clearly that the duration of amenorrhea, as you might expect, predicts the extent of bone loss. But testosterone and dehydroepiandrosterone also have effects on bone, and these are mediated through the aromatization of these steroids into estradiol and estrone, but they also have direct bone anabolic and anti-resorptive effects. And athletes with amenorrhea in red have lower estradiol and testosterone levels than the eumenorrheic athletes in blue. Now, moving on to the growth hormone IGF-1 axis. So growth hormone stimulates both systemic and local IGF-1 secretion in bone, and growth hormone both directly and through IGF-1 is bone anabolic and increases bone formation. So in girls with anorexia nervosa, we have shown through frequent sampling overnight that concentrations of growth hormone are significantly higher than in controls, as shown in the figure at the bottom. But despite, and we think of these higher growth hormone concentrations in conditions of low energy availability as adaptive. So growth hormone is gluconeogenic, and increasing a gluconeogenic hormone would be appropriate adaptation to try and maintain a state of euglycemia in a condition that is prone to hypoglycemia. However, despite the higher growth hormone concentrations in anorexia nervosa, these girls have very low IGF-1 levels. And this suggests a resistance to growth hormone effects at the level of the liver that is nutritionally acquired. Similarly, we've shown that amenorrheic athletes have lower IGF-1 levels than non-athletes, and the eumenorrheic athletes are somewhere in between. And the figure that I just pulled up here shows the association of growth hormone concentrations with osteocalcin, which is a bone formation marker. And in healthy controls in blue, we see the expected positive association of growth hormone and osteocalcin. And this is expected because growth hormone is a stimulator of bone formation. But in the girls with anorexia nervosa in red, we see that despite the higher growth hormone concentrations, this association is completely lost. And this suggests that in addition to a resistance to growth hormone at the level of the liver, there's also resistance to growth hormone at the level of bone in anorexia nervosa and in general in conditions of low energy availability. Now, low IGF-1 levels, as one might expect, are associated with low bone density, and low IGF-1 levels also have a deleterious effect on ovarian function, and with an improvement in energy availability, there's a normalization of all of this. And now, in terms of the hypothalamic pituitary adrenal axis, we know that high cortisol levels have multiple deleterious effects on bone, and amenorrheic athletes have significantly higher cortisol concentrations measured overnight by frequent sampling as compared to eumenorrheic athletes and non-athletes. And this, again, is adaptive because cortisol, like growth hormone, is gluconeogenic. And we know that high cortisol levels inhibit gonadotropin-releasing hormone pulsatile secretion. And as the figure shows, there is an inverse association of cortisol with LH. So the higher the cortisol, the lower is LH pulse mass on frequent sampling. Further, high cortisol levels are associated with low bone density, and with weight regain, there is a reduction in cortisol levels associated with an improvement in bone density. And with regards to the appetite regulating hormones, there are a bunch of these that seem to impact bone health. I'll just talk about three: leptin, ghrelin, and PYY. So leptin is an adipokine which inhibits appetite. PYY is made by the distal gut in response to food intake, and it inhibits appetite as well, while ghrelin, which is secreted by the fundus of the stomach, is an orexigenic hormone. And all three have an impact on bone. So PYY inhibits osteoblasts, while leptin and ghrelin stimulate osteoblastic activity and bone formation. So we showed in the study that was first authored by Carla Cristo that amenorrheic athletes have lower levels of leptin and higher concentrations of ghrelin and PYY than eumenorrheic athletes and non-athletes. And the lower leptin and the higher ghrelin would be appropriately adaptive because leptin inhibits appetite, ghrelin stimulates appetite. So put together, that should lead to a stimulation of food intake, which is what one would want to see. We don't understand why PYY is high in amenorrheic athletes. We've also shown that PYY is high in anorexia nervosa versus controls, and PYY inhibits appetite, so this should actually go down in conditions of energy deficit, but we do see these higher concentrations that we do not understand. Now, all three have an impact on the hypothalamic pituitary gonadal axis, which is inhibited by ghrelin and PYY, and the low levels of leptin would also lead to an inhibition of this axis. And the figures show that higher ghrelin concentrations and lower leptin concentrations are associated with lower LH pulse mass. And in terms of the impact on bone, ghrelin is bone anabolic, and we have shown positive associations of ghrelin with bone density in healthy controls, but not in conditions of low energy availability, suggesting a state of ghrelin resistance, just as there is a state of growth hormone resistance in these women. And leptin is again bone anabolic, and it's again positively associated with bone density. I'll talk about the role of leptin replacement in a few slides. And PYY inhibits bone formation. We have shown inverse associations of PYY with markers of bone formation shown in the figures at the bottom. So the higher the PYY, the lower the bone formation markers. And we've also shown an inverse association with bone density, suggesting a role for a PYY antagonist. So to summarize what I've talked about so far, low bone density is prevalent in oligoamenorrheic athletes, and it's associated with a higher risk of fracture, particularly stress fractures. And there are certain kinds of athletic activities that increase the risk of oligoamenorrhea and low bone density. And the mechanisms of low bone density include changes in body composition and many endocrine changes that I've talked about, and some that I've not had a chance to talk about today. So now moving on to, well, what do we do about low bone density? How do we assess this? How do we treat this? And the Endocrine Society guidelines indicate that one should obtain a baseline bone density by DEXA in any young woman who has 6 or more months of amenorrhea, or even earlier if there is a history or a suspicion of nutritional deficiency, as in anorexia nervosa, and or if there is a history of skeletal fragility. And the sites for assessment of bone density, as you know, include the spine and the whole body, less head for children and adolescents, and the spine and the hip for adults. And how do we define low bone density? Now, the ISCD defines low bone density as a bone density Z-score of less than -2. But does this apply to athletes? So I've told you that mechanical loading should lead to an increase in bone density above average to withstand the impact of bone loading activities and to prevent fracture. And I've shown you that human or weak athletes at certain sites have higher bone density than non-athletes. And Michelle Barak's group has shown quite conclusively that in athletes who are engaged in weight-bearing sports, a bone density Z-score of less than -1 rather than -2 is predictive of stress fracture. And so based upon this, the American College of Sports Medicine and the Female Athlete Triad Coalition has indicated that for weight-bearing sports, a bone density Z-score of less than -1 should be considered to be low. So our patient had bone density assessment done, and her spine and hip bone density Z-scores were really low. The spine was profoundly low. Now, this is not in every athlete that comes to us. And I purposefully picked this case just because I wanted to go through the entire management of this patient in terms of the different strategies for management when you have such low bone density measures. So what do we do with her? And that brings me back to the different mechanisms. So we want to address these mechanisms, but the underlying factor that leads to all these other changes is low energy availability. So you want to try and address that situation. And this requires putting in place a treatment team for lifestyle interventions to increase caloric intake, reduce expenditure, or both. And at the same time, it is really important to optimize micronutrient intake, including vitamin D levels, and to be sure that the patient is consuming a sufficient amount of both vitamin D and also calcium. So this is what the treatment team should look like. There should be a physician and also an endocrinologist to coordinate care, monitor menstrual status, a dietitian to assess the energy status of the athlete and to recommend dietary modifications, a mental health professional if there is an eating disorder involved as well. And it's very, very important to loop in the parent and the athletic trainer or coach who can monitor adherence to treatment, support the athlete's recovery, monitor training modifications, and exercise performance. Now, in low-weight individuals, weight gain is essential for the spontaneous resumption of menses and improvement in bone density. And the goal should be to aim for a body weight above that at which menses were lost, or a body weight that corresponds to more than 90% of median BMI, or a BMI of at least 18.5. And this is based upon studies by Neville Golden's group that showed that in girls with anorexia nervosa, at the time of menses recovery, body weight on an average was about 2 kilograms greater than that at which menses were lost. And the average body weight at the time of menstrual recovery was about 91.6% of median BMI. But we can see that there's a huge standard deviation in that number. So there is significant variability in that set point. And so the point at which menstrual recovery occurs can vary very much, a great deal from one individual to another. And the study also showed that it can take 6 to 12 months of being at more than 90% median BMI before menses resume. So some patience is required once patients get to a healthy weight, and that's important to emphasize to patients as well, because they can lose patience at that point of time. Having said that, if there is persistent amenorrhea, despite being at a healthy weight for many months, one should consider alternative causes of amenorrhea, such as persistent emotional stress or even underlying PCOS. Now, this figure shows the change in bone density over a one-year period in healthy controls in blue who have the expected increase in bone density over time, girls with anorexia nervosa who do not gain weight or resume menses in red who have a decrease in bone density over time, and girls with anorexia nervosa who gain weight and resume menses in green, who have an improvement in bone density, though maybe not quite to the extent that you would like to see and what we see in controls. So our patient with the low bone density measures had a treatment team put in place. Her vitamin D status was optimized. And over 6 months, her weight went up to 140 pounds, which was 93.6% median BMI. But she remained amenorrheic. And so this can happen. So the patients get to goal weight and they still remain amenorrheic. And she had another stress fracture. So this is the change in BMI over time. So what else might you want to consider at this time? And is this the right time for estrogen replacement? And so the Endocrine Society guidelines indicate that after 6 to 12 months of non-pharmacological treatment and further exercise restriction, one may consider estrogen replacement therapy. And I think we all know at this point that giving estrogen as a birth control pill is not effective in improving bone density in patients with functional hypothalamic amenorrhea. This is just one study in adolescents with anorexia nervosa between 11 and 17 years old. And the figure shows the change in bone density at the lumbar spine and the hip in the girls who were randomized to the oral contraceptive pill in white versus placebo in black. And we can see that there really is no difference between the groups in terms of changes in bone density over time. Now, this lack of efficacy of oral estrogen has been attributed to its IGF-1 suppressive effects because of hepatic first pass metabolism. And this is very important in adolescents when levels of IGF-1 go up a lot and really contribute to bone accrual. And so if oral estrogen is not effective because it suppresses IGF-1, would giving estrogen by a non-oral route be more effective by bypassing hepatic first pass metabolism? So what about giving estrogen transdermally or vaginally or sublingually? And we have data for the transdermal route of estrogen administration. So this was a 12-month RCT that we conducted in oligoamenorrheic athletes between 14 and 25 years old. And the first author of this paper was Kate Ackerman. And the figure shows the % change in bone density at different sites in the athletes who were randomized to the transdermal estrogen patch shown in red versus the combined oral contraceptive pill shown in white and no estrogen shown in black. And as you can see, the patch group had a significant improvement in bone density at multiple sites compared to the pill group and the no estrogen group. And here are data for HRPQ-CT endpoints showing that at both the distal radius, a site of non-weight-bearing bone, and the distal tibia, a site of weight-bearing bone, the patch group did much better than the pill group and the no estrogen group for increases in cortical area, cortical thickness, and total volumetric bone density. Now, we've also shown that the patch versus the pill group had greater improvements in tibial trabecular number and trabecular volumetric bone density. And there have been a few other studies that have also shown the efficacy of the patch versus the pill. And at this point of time, I think it's quite conclusive that the transdermal estrogen patch, but not the pill, is effective in improving bone outcomes in functional hypothalamic amenorrhea. And I just want to point out that when I talk about the transdermal estrogen patch, this is the transdermal 17-beta estradiol patch, not the ethinyl estradiol patch. That has not been studied. And we did show in a subsequent paper that was first authored by Vibha Singhal that IGF-1 Z-scores did in fact go down significantly in the pill group in white versus the patch in the no estrogen group. And we also had a significant increase in IGF binding protein 3 in the pill group compared to the other two groups. So the bioavailable levels of IGF-1 would actually be even lower than indicated by the IGF-1 Z-scores. And commensurate with a reduction in IGF-1 Z-scores in the pill group, there was a significant reduction in P1NP, which is a bone formation marker in the pill group compared to the other two groups. And the girls with the greatest reductions in IGF-1 had the greatest reductions in P1NP. And this is consistent with IGF-1 suppression, contributing to the lack of efficacy of the oral pill. Now, estradiol levels went up in the patch group, but not the other two groups. And the reason it did not go up in the ethinyl estradiol COC group is because ethinyl estradiol is not picked up by the estradiol assay. Now, sex hormone binding globulin levels went up significantly in the pill group and not the other two groups. And this would suggest lower levels of bioavailable estrogen in the pill group compared to the other two groups. And the girls who had the greatest increases in estradiol had the greatest increases in P1NP, which is a bone formation marker, and the greatest increases in bone density. Further, the patch group had reductions in sclerostin and PREF1, which otherwise inhibit bone formation. And in a subsequent pilot study, we showed that, that in terms of the impact of transdermal estradiol on marrow adipose tissue, there was a decrease from baseline to 12 months in lumbar marrow adipose tissue with transdermal estrogen administration. And cortical volumetric bone density went up with transdermal estrogen from baseline to 12 months at both the distal radius and the distal tibia. And the reduction in marrow adipose tissue correlated with increases in bone density, even after controlling for other things that would change with these medications. So based upon these and other studies, the Endocrine Society guidelines suggest against using the oral contraceptive pills in functional hypothalamic amenorrhea for the sole purpose of regaining menses or improving bone density. But they do suggest the short-term use of transdermal estradiol with cyclic progestin if menses do not resume after 6 to 12 months of a reasonable trial of nutritional, psychological, and exercise intervention. And one thing to really emphasize to your patients is that if you're giving them transdermal estrogen with cyclic progesterone, that has no contraceptive efficacy. We actually had a pregnancy happen in one of our studies, so this is really important to emphasize. So our patient was started on transdermal estradiol with cyclic progestin. This was the 100 microgram estrogen patch. And with this, she maintained her estradiol levels in the so-called therapeutic range. The 25 hydroxy vitamin D levels continued in the normal range. And her spine bone density Z-score went up from -4.7 to -3.6. And the hip bone density Z-scores from -2.4 to -1.5 over a 1-year period. But this is still very low, and she continues to have stress fractures every few months. So what more would you want to do at this point of time? And is this a good time to consider working a workup for osteogenesis imperfecta, because some of those mild cases can be quite subtle. And so we did actually get a 23 gene OI panel for her, which was negative. And this is kind of relevant because we know that bisphosphonates would help in OI. And so if the patient has OI, you would treat with bisphosphonates. So what other treatment strategies could we consider for our patient? And this brings me to various bone anabolic agents such as DHEA, IGF-1, leptin. These three are all experimental at this point. And then we have teriparatide, abaloparatide, and romosozumab, which have been used quite effectively in postmenopausal women and older men. And then there are the anti-resorptives, certainly the bisphosphonates and also denosumab, which again have been used very effectively in postmenopausal women, older men, in glucocorticoid-induced osteoporosis, and bisphosphonates and OI. And then what about combination therapy? So with regards to the bone anabolic agents, this is a study that was done by Catherine Gordon's group at Boston Children's. And this was an 18-month randomized controlled trial of a combination of a combined oral contraceptive pill with dehydroepiandrosterone. And that combination regimen is shown to the left versus placebo to the right. And what you see, and so this was a study in older adolescents and young women with anorexia nervosa between 13 and 27 years old. And the study showed that the combination regimen to the left again had led to a maintenance of bone density Z-scores over time that was not seen in the placebo group. So this was encouraging also in at least maintaining bone density Z-scores over time. But the same group then published the second study, and this was a 12-month RCT in younger girls with anorexia nervosa between 11 and 17 years old. And here the data looked very different. So if you look at the right, so that group includes girls who had closed epiphysis and were done growing. And in this older group within this younger age range, the combination regimen did not really differ from placebo in terms of bone impacts. Is that for here? Okay, all right. At both the lumbar spine and the whole body. And then when you look at the left, that shows girls with open epiphysis who were still growing. And in this group, the combination regimen actually fared worse than the placebo group. And so while this combination regimen may be effective in young adults to maintain bone density Z-scores over time, it is not effective in adolescents with anorexia nervosa and may in fact be deleterious in those who are still growing. Now, what about IGF-1? So this is bone anabolic, and we've shown in a study that giving IGF-1 for a short duration, this was a 7 to 10-day period, does lead to an improvement in bone formation markers and an increase in P1NP shown here versus the group that did not receive IGF-1. And these are data from a study that was done by Steve Grinspoon in our group many years ago, in which adult women with anorexia nervosa were randomized to receive either IGF-1 with a combined oral contraceptive pill shown in red, or IGF-1 alone, or estrogen alone, or neither. And the group that received the combination regimen of a bone anabolic and an anti-resorptive did have an improvement in bone density compared to the double placebo group. Having said that, we then followed this study by a second study, and Vibha Singhal was the first author of this paper, where we gave IGF-1 or placebo to girls who all of whom received transdermal estrogen. And that study showed that adding IGF-1 to transdermal estrogen does not further improve bone density. So giving IGF-1 when you give a birth control pill improves bone density versus double placebo, likely because the addition of IGF-1 prevents that decrease in IGF-1 that should occur with a birth control pill. But when you give transdermal estrogen and there is no suppression of IGF-1, giving additional IGF-1 does not seem to help. And this figure to the right shows data from a study of metroleptin versus placebo. So leptin is also bone anabolic, and this study was a 3-month trial in adult women with functional hypothalamic amenorrhea. And the study showed that leptin did lead to an improvement in bone formation markers over time, but leptin is anorexigenic, and the women who had leptin reported a subjective reduction in appetite and had a significant reduction in body weight, which is what you see there compared to the placebo group. So not what you want to see in conditions of functional hypothalamic amenorrhea. And then in terms of teriparatide, so teriparatide is a pretty potent anabolic agent. And this was a study that we did in older adults with anorexia nervosa. Poona Fazali was the first author of this paper. And this was a 6-month RCT that showed that teriparatide in red led to a significant improvement in spine bone density over time compared to the placebo group. But we have no data for teriparatide in adolescents and not in functional hypothalamic amenorrhea. And so far, we have no data in functional hypothalamic amenorrhea for abaloparatide or for romosozumab, although we are in the process of conducting a romosozumab study in adults with anorexia nervosa at this time. And in terms of anti-resorptives, so bisphosphonates are, very potent anti-resorptive agents. And this was a study that Karen Miller was the first author of, so in this study, this was a 12-month RCT of risedronate, which is an oral bisphosphonate, shown in red versus placebo in black. And this study showed that there was an improvement in spine and hip bone density Z-scores with risedronate compared to placebo. The figure shows the effects on spine bone density. And so this was encouraging for sure. And more recently, our group has published this paper, and Melanie Haynes is the first author of this paper. And this was a 12-month RCT in adults with anorexia nervosa, in which the women were randomized to one of 3 arms. The first arm received 6 months of IGF-1, so a bone anabolic hormone, followed by 6 months of risedronate. The second arm received 12 months of risedronate alone, and the third arm received 12 months of double placebo. And the study found that there was an improvement in lateral spine bone density with risedronate compared to placebo, but no difference between the sequential therapy versus bisphosphonates alone in terms of PA spine bone density, which is typically what is reported in DEXA scans. And for HRPQ-CT and endpoints, there was an improvement in peripheral bone density, peripheral volumetric bone density, with the sequential therapy in red versus placebo in black. But not so much in terms of total intrabecular volumetric bone density, although we see similar trends, but it was just not statistically significant. So given that these are small differences and probably not that significant, we're not rushing to recommend the sequential therapy. And importantly, in adolescents with anorexia nervosa, Neville Golden's group did this study of alendronate versus placebo, and they reported no significant difference between the groups in terms of change in lumbar spine bone density with alendronate, although small increases were noted at the femoral neck. Now, there have been concerns expressed about using bisphosphonates in children because of their very long half-life and the possibility of teratogenicity. Having said that, the data so far seem to be quite reassuring in this regard. And for denosumab, we just published data from a pilot study, and Melanie Haynes is the first author of this paper as well. And this was a 12-month RCT in adults with anorexia nervosa, in which the women were randomized to receive denosumab or placebo for 6 months. And the study showed a significant reduction in bone turnover markers, both CTX, shown to the left, and P1NP, shown to the right. So CTX is a bone resorption marker, P1NP is a bone formation marker, and both went down with denosumab versus placebo. And with that, there was an increase in spine bone density in the denosumab group compared to the placebo group, and an improvement in several HRPQ-CT endpoints as well. Now, the Endocrine Society guidelines suggest against using leptin because it is anorexigenic and reduces body weight. against using bisphosphonates because of their very long half-life, and against using denosumab because at the time there were no data for denosumab to improve bone density in young women with functional hypothalamic amenorrhea. Having said that, I would submit that in women, particularly adult women who are continuing to have fractures, despite being on estrogen replacement, that bisphosphonates should be considered as an option. Now, the guidelines also indicate that in rare adults with functional hypothalamic amenorrhea, one may consider the short-term use of recombinant PTH, so teriparatide, in the setting of delayed fracture healing and very low bone density. So our patient did receive 3 months of teriparatide to take advantage of the bone anabolic window of teriparatide, which lasts just a few months. And then we followed that with zoledronic acid infusions that she received annually. And finally, her stress fractures stopped. Her spine bone density Z-score is now negative 2.4, so still low, but a significant improvement from the negative 4.7 that she started at. And her hip bone density Z-score is now normal. So with that, I want to summarize what I've kind of talked about today and the message I really want to give. And that is that the treatment of functional hypothalamic amenorrhea and the associated low bone density in athletes really requires a treatment team to be put in place that is multidisciplinary. And that one should give everybody, these young women, a reasonable trial, at least 6 to 12 months of lifestyle modifications, and also optimize vitamin D status. And following this, estrogen replacement does become necessary, and this involves the continuous use of transdermal 17-beta estradiol with cyclic progestin and not a combined oral contraceptive pill. And there are certain women in whom you might want to then move on to other therapies, including possibly teriparatide with or without bisphosphonates. So I'll end here by acknowledging all the people that have contributed to these studies that can be incredibly difficult to recruit for and complete. And particularly the study coordinators who do such a tremendous job of, again, the recruitment and retention. So thank you very much for your attention, and I'm happy to take any questions.
Thank you, Dr. Misra. I will pass the microphone.
First of all, thank you for a very fabulous talk. This was a lot of information and very useful one too. One question that I do have is, you mentioned starting estrogen replacement after 6 to 12 months trial of a lifestyle modification. What would be the end point to take them off and see if they start their cycles again, even if they've gained to 2 kilos and have not responded?
Yeah, so that's a great question, and there's no terrific answer to that. So typically what I do is I wait for them to get to a healthy weight and to be at that at a healthy weight for several months. And then I'll give them a trial of estrogen and see if they have spontaneous menses.
I had a futuristic question almost. You know, I feel we're following these athletes, and then we are looking at the bone once they become amenorrheic. Do you think at any time or point we'll come to a stage where every athlete will get a BMD, then we can monitor their accrual and, you know, say that, okay, this is not optimal kind of stuff?
So the answer is yes. Now, you know, I talked a lot about the Endocrine Society guidelines. There's a whole separate set of guidelines that the Female Athlete Triad Coalition has put forth. And their guideline is a lot more detailed than the Endocrine Society guidelines are. And they talk about risk factors for stress fractures and basically for the athlete triad. And that takes into account body weight. It takes into account the presence of eating disorders or not, the age of menarche. It takes into account the number of missed menses over the preceding 12 months, any evidence of low bone density from earlier times, or any evidence of stress fracture. And if there is, you know, if any patient has one high-risk triad criterion or 2 or more low-risk triad criteria, they do recommend bone density assessment. So you do not need to be amenorrheic. Amenorrhea definitely would push you towards getting bone density. But if you have a really low body weight or an eating disorder or a late age of menarche, you know, all of that would be reasons to get a bone density.
Thank you. Chad, yeah.
Oh, yeah. Can you give an example of a name for 17 beta estradiol patches? So yeah, there's so many of them right now. Let's see. I actually just type in 17 beta estradiol patch and they all come up, and it depends upon the patient's insurance. We typically use a viable dot patch, but then I think there's also the estraderm, and then I hate to give brand names when I'm doing talks, but typically we do the viable dot or the estraderm, and there probably are others. And let's see, any other questions? What is the utility of checking gonadotropins on testosterone treatment? No, this is for the Klinefelter talk, I think. Okay. Yeah. That's it.
That's any other questions? Excuse me.
Thank you again, Dr. Misra. Just reiterating a little bit, because the 17 beta estradiol does seem to have a significant difference in other preparations. Do we have an idea? Do we think it's first pass? Do we think what is leading to the higher efficacy with 17 beta versus some of the other estrogen preparations?
So I didn't show you the data. I just kind of talked about this in passing. So one of the things that we do know is that 17 beta estradiol leads to a significant reduction in sclerostin and pre-adipocyte factor 1. And I didn't talk about those. There's just too much to talk about. But then those are very potent factors that inhibit bone formation. And so we think that that property of 17 beta estradiol is important. Now, what is really hard to sort out is, how much is 17 beta estradiol versus ethinyl estradiol in the birth control pill? How much is transdermal estrogen versus oral estrogen? So one of the questions I often get asked, and this is probably a good thing to discuss here, is, what about giving oral 17 beta estradiol? So if it's more the preparation rather than the route, would oral 17 beta estradiol help? And the answer is that it would probably be better than ethinyl estradiol in the birth control pill, mostly because it doesn't cause as much of a reduction in sex hormone binding globulin, as much of an increase, of SHBG levels. But then when you look at studies that have compared the transdermal 17 beta estradiol patch versus the 17 beta estradiol pill, there is still a significant reduction in IGF-1 levels with oral 17 beta estradiol versus the transdermal route. So I think if you had to compare transdermal estradiol, oral ethinyl estradiol, the greatest effects or the positive effects on bone would be with the transdermal 17 beta estradiol patch, followed by the 17 beta estradiol pill versus the oral the combined oral contraceptive pill. The other issue that we often come across, not often, but every now and then, is with the patch as well. There are people who are very, very who find it very irritating. So they have reactions to the patch. So what do you do in those patients, and how do you keep them from have them continue to apply it? So one of the things we've tried is Benadryl ointment or a cream. So we first apply the Benadryl cream, and then once that dries up, then we ask them to apply the patch, and that sometimes helps. And if that is also not effective, we've actually tried hydrocortisone creams, and that seems to be effective. But then there are some people. There was one patient I remember in our study who actually had significant urticaria with the patch, and so we had to drop her from the study. We could not give the patch to her. Okay.
I had one other quick question. You talked briefly about the effect of muscle mass on bone, and are they looking at myokines, the effect of myokines, and specifically in this condition with eating disorders?
Yeah, so I'm really hitting myself in the head right now because we did a study of irisin and FGF21, thinking about myokines in athletes and non-athletes. And I can't remember what we showed in that study, so my apologies. I'm happy to send you the paper at some point.
Thank you.
And I thought I would look that up today, but basically it did not show, it did show that irisin was lower in the athletes than the non-athletes, and that correlated with low bone density. But then it didn't really, I don't think that held up after we controlled for body weight changes, but I just want to be sure that I'm not misspeaking. So I'll look that up and let you know.
Absolutely.
Yeah, but it's an important point because, the question is, would some of those, would medications that mimic those myokines have an effect if, and that actually would be very relevant in conditions such as anorexia nervosa, where, lean mass is so profoundly impacted.
Any other questions from the audience? Thank you, Dr. Mishra, for an absolutely wonderful talk.